Hello and welcome to another edition of the InnovAiT podcast. My name is Dr. Sadiya. I work as a GP and a trainer in Southwest London. And in today's podcast, I have the pleasure of having with me hosting the podcast Dr. Matilda Ehsan. Matilda is currently working as a salaried GP 3 days a week at a practice in northeast London. She completed her GP training in August last year, and she will be telling us a little bit more about how her experience has been during training in COVID and also post CCT. Welcome, Matilda, to the spring edition of our InnovAiT podcast.
Hi, Sadiya. Thanks for having me.
How are you doing today?
I'm good. It's nice that the weather's getting better, isn't it?
It is. That always makes a difference when we've got the sun out. That's right. So, Matilda, once again, thank you so much for joining us for this podcast. It's really brilliant to have you on board. Now, we have a couple of interviews along the way. But first of all, I would like to have you share your experience with us and our listeners, telling us a little bit more about what last year was like for you working as a trainee in the middle of COVID, how that experience was. We've been talking a little bit beforehand about how that was for you, and you were mentioning the remote working and also how busy your practice was and having staff who then had to go off sick as well with COVID. So you were based at a practice in Woolwich, I understand, for your training, which is quite a large practice. Tell us a little bit more about how all of that went for you.
Okay, so wow, training in COVID during COVID times was definitely a surprise. I remember probably, I think it was late February. We were all kind of, having our staff meetings, and COVID seemed very far away, and we had all these things that if patients had come from certain areas with temperatures, but then obviously we had all these procedures in place, and I don't want to say we didn't take it seriously, but it just seemed so distant. And I remember those times me and myself and my colleague, we were preparing for our CSA because we were the March sitting. And I just remember, like, in the run-up, we were going into the practice to practice for the CSA. And then all of a sudden, so my CSA was on the 14th of March, if I recall correctly. And I remember getting ready in the morning and thinking, oh my gosh, is my CSA exam going to happen today? Because I think at that point we weren't in full lockdown, but I think it was, COVID was very much in the UK at that point, and it was, the fears about everything was growing. So I remember the anxiety on the morning of the CSA, wondering if I was going to get to do my exam and feeling upset because I just wanted it over and done with. But I was fortunate, and I was one of the last set who managed to do my CSA. But actually, our CSA was what we call a no-touch CSA. So we weren't allowed to touch the patients, and they'd had to make accommodations, and they'd had to kind of swap out the older patients for younger patients due to the CSA risk, and it was all really weird. And so they were like, if you have a 51-year-old who looks like a 30-year-old, we're not playing tricks. It's supposed to be 51, but patients are now shielding. So the CSA part was quite crazy, but I was relieved and lucky to be one of the few who, even now a year later, was probably the last set of people who got to do the CSA. In regards to training was weird. We had kind of VTS was kind of temporarily taken away so that we could help out on the practice. So our VTS days were Wednesdays, so we didn't have our Wednesday afternoon anymore. We were clinical. And I have to be honest, it was stressful. It was scary because up until that point, we didn't really have the practice that we were at. The trainees didn't really do that much telephone consulting. So that was different. It was definitely a very different time for us.
Sure, no, I can imagine, and certainly, having similar trainees in our practice, share, and echoing the words that you're saying in terms of how strange it was. I think it was strange for all of us, in fact, not just for trainees, getting used to a very different way of working, familiarizing ourselves with new IT systems and video consulting, and like you say, we haven't really had much experience, not either as trainees or even GPs who've been doing the job for many years. I think it's something we've always thought about, that this is the way general practice was very much heading with remote consulting,
Yes.
but we never thought it would happen so quickly and almost overnight.
Literally,
Yeah.
I remember like prior to COVID, like things like Babylon and was it GP at Hand? All those things like were almost like remote consulting was like purported to be like the devil, and then all of a sudden we were all kind of like scrabbling to figure out how to use all these like different, how do we video consult, how do we telephone consult, and I remember that flurry was crazy.
That's right. How did you find the whole experience of familiarising yourself with new IT setups, and how did you find that your patients felt that experience was for them?
So I think, so what I would say is that initially, when they were like trying to show us, oh, this is how you send a sick note using this company, I was just, in my head initially, I felt quite resistant. I was just thinking, what is all of this? Like, this is not what we signed up for. But then I think within a few days, I realized that, oh, I'm not going to be able to survive if I don't figure out how to send things via, text, like sick notes, blood test forms, whatever you need to send via text. And in terms of patients, actually, I think I think it was probably the older patients and those who were not necessarily tech savvy who I think then suffered, and I think now are still suffering. Though I don't want to say older patients and lump everyone in, because I've got 60 and 70-year-olds on my list now who send me photos, who can do video consult. So I think the beginning it was mixed feelings, but now that we've all been doing it for a year, I think people do find it more convenient because people are out shopping, they're out at work, and they can still get to speak to their GP without having to physically come in.
No, absolutely. I think for a lot of people, that can be a huge advantage, can't it? But there
Yes.
are certainly, we have vulnerable groups as well who will struggle either with the technology, or having that need to come in and see their doctor or nurse. So, what would you say, Matilda, were sort of the biggest challenges for you over the year as a trainee, as an ST3 during COVID? What was the support like from your practice, and what sort of advice would you be giving to trainees who are currently in that situation?
I would probably say the biggest thing you have to do is, if you don't like tech, you've just got to go into it head on, and you just need to spend the time. It might be away from clinic, just like kind of having a play and seeing how to do it, because I think even things like video consult, it sometimes can take you a bit of getting used to in regards to how you send the link. And actually, one important thing that I think is key to realize is there is a lag time from when you send the text. So it's not like when you send a text to your friend. None of us really know how the computer system works. You just know that you send a text and the patient gets it. But I have noticed that there's a lag time. So oftentimes you might be on the phone and say, oh, I'm going to send you a link, and the patient will say, oh, but I don't have it. So I will usually say things like, you should have it by the end of our phone conversation. So that's important. And I think some of the other things is appreciating people's situations. So, myself and my colleague, we were talking about, data poverty. Like some patients just don't have the data to send you photos. And I think, or they don't want to come out and say it. So they might say things like, oh, I don't know how to do it, or it's a bit difficult for me.
Yeah.
So I think also learning how to read in between the lines is really important, so that we're not depriving people of care because of the situation that they find themselves in.
Yeah, no, that's a really important point. Yeah. And your top tips for trainees at this stage?
Top tips. So I guess for the RCA, even though I didn't do it, one of the things that I would say is start doing your recordings early, start practicing early, and the reason why you do need to do it early is because the difference between the RCA and the CSA is the CSA, the patients are, what we call simulator patients. They're actors. So they have a script that they keep to. Whereas RCA are real patients who don't have a script, and they might not have a knowledge of the fact that that's the one time where you actually have to finish your consultation in 10 minutes.
Yeah.
So you might find that you've done a brilliant recording, and then at 9 minutes 50, the patient brings a new problem. So I think trying to accommodate for those kind of things is difficult. I know some trainees have kind of, had conversations with patients and said, look, this is a recording, this is for an exam, just so that they're aware of kind of, the background to what's happening. But I think my key advice is, start early. And I think there is still value in the CSA books in terms of the breadth of cases that they cover. So you can still use the cases, you can still practice with friends. Obviously, you're going to be doing your exam on, real life patients, but in terms of the management of cases, they're still relevant in regards to what the CSA books have to offer.
Yeah, no, that's really good advice. No, thank you. We talk a lot about burnout, don't we? It's sort of the buzzword out there, and looking after our mental health and well-being. And it's great that so many more of us in the healthcare profession in particular are acknowledging this. And I think for trainees in particular, having that support is so important. Do you feel as a trainee you were given enough support going through all of this? And do you feel the college could have supported you more? Or were there other ways? How were you getting your support throughout all of this?
So I think if we start with the college, I think during that time there was definitely a lot of uncertainty, especially for people who didn't get to do the physical exam, who then suddenly at last minute were told they would have to do a recorded assessment. I think it was a really stressful time, and I think in hindsight trainees were very upset because it was a high stress situation. But I think when I look back on the college, they tried their best to communicate the information that they had available to them, if that makes sense. Because I think what many of us trainees forgot at that time is that there were lots of stakeholders. So there was the GMC, there was the fact that the exam, needed to be, almost equal to the CSA, but obviously COVID secure. So from that respect, I think the college did try their best. And I think during that time, and even now, the college had lots of free resources and kind of I think it was Webinar Central on things. So that was good. I think in terms of support from the practice, I think they got us all these telephone headsets, which again, initially I was like, what is this contraption? Why do I have to have this thing glued to my head? But actually now I can't live without my headset, because it's really hard to have patients on speakerphone and trying to type as well. And then if you don't have them on speakerphone, you have the phone on your ear, and then you've got your head bent, and then you get neck pain.
That's
or you're
right.
crouching over your desk. We've all been in that position where you're crouching over your desk.
Yes.
Trying to hear, and then you're trying to type, and then all the patient can hear is you typing, and you both get upset with each other. So I think the one biggest thing that the practice gifted to us at the time, which initially I was like, as I said, what is this? I was really happy with, was a telephone headset. So I would say any practices out there, if possible, and they don't have to be expensive, including trainees, everybody should have a headset. It makes life so much easier, and it saves you a lot of neck pain.
Yeah. Absolutely, a very, very useful point. Thank you for bringing that up. Great, so let's move on nicely to our first podcast that you have interviewed Dr. Popliton for. I believe that's something that we're covering in terms of anxiety. Tell us a little bit more about this podcast, Matilda. How did you approach this? What was your reasoning behind choosing this podcast, and how did it go?
So it was anxiety in adolescence, and I guess the reason why I probably ended up picking this one is I think obviously anxiety in adults is really kind of well recognized. We know that we can use medication, we know that we can use time to talk, all of these things. But I think anxiety in adolescence is difficult because what we often find in practice is that many of our anxious kind of teenagers, they do have very real anxiety issues, but the services they just don't seem to be available to help us to kind of manage them. Like, the structure is not the same. Obviously, yes, we can refer to the child and adolescent mental health service, but oftentimes most of our anxiety patients, they don't necessarily meet the CAMS criteria. So it now becomes kind of a community thing for you as the GP to manage. So I think, I don't know if I would say it was selfish interest, but I was like, this is something that I think I don't quite have a clear handle on. And I really like the fact that the article kind of highlighted lots of useful resources for adolescents, some of which I think I still use now, with the apps and stuff, and how to approach it. And that was the main reason really for picking it.
Brilliant. Well, why don't we have a listen and find out a bit more about this? Thank you.
No worries.
Today I'll be joined by Dr. Aaron Poppleton, who recently co-authored an article on anxiety in children and adolescents in the November edition of InnovAiT.
Great. Thank you for having me. I'm an academic GP based up in the northwest at the University of Manchester. And I chose this topic as it relates to the research that I'm doing on mental health.
More and more children are being diagnosed with ADHD and autism. You suggested that anxiety is more common in children with ADHD and autism. Does anyone know why?
Yeah, so around 40% of people on the autistic spectrum are thought to suffer with significant levels of anxiety. And there's been a number of underlying factors associated with anxiety in people that are on the autistic spectrum. And this includes things like the need for having routine and structure within the daily activities, having hypersensitivity to stimuli, difficulties regulating emotions, and that can factor into things like understanding and controlling feelings in different situations. Now, it can be hard to control different situations that you come up with in a day, and anxiety can be triggered in people with ADHD or autistic spectrum when they come into contact with new people, or maybe unfamiliar tasks, or perhaps even unfamiliar or unpleasant sensations. And these things can be hard to predict and hard to control, which can lead to symptoms of anxiety. Also, the way they respond to these sorts of factors can also put them at risk of social pressures around them and being misunderstood and even being teased or bullied by others.
Thank you for shedding light on that. It's really helpful for us to keep this in mind when consulting. On the other hand, consultations with children and adolescents can be challenging. Do you have any tips for GP trainees on how to aid comfort and communication within the consultation?
Yeah, so you're right, that consultations can be challenging. And I think young people with symptoms of anxiety can present to primary care either on their own, but more often with somebody with them, like a parent or a carer, one of their friends, or even somebody else that they felt confident to come with. And I think the way that you approach the consultation depends on the age and developmental stage of the young person that's coming to see you. I think, as is the case in all consultations, you need to be sensitive, non-judgmental, and allow time to build rapport with the person in front of you. Good communication skills are essential, I think particularly in slightly more challenging consultations like these. So things like open questions, using relatable examples when explaining things, and being careful as to which non-verbal cues that you're giving, and avoiding medical jargon. And these sorts of things can build a relationship and help young people to open up. I think it can also be useful spending time separately with the parents and the young person if possible, particularly if you're asking about sensitive topics or how they're feeling. We all know that things like relationships and topics such as abuse or drug and alcohol use are difficult to talk about when somebody you know and love is in the room. So this can be a way to approach some of these topics. I think it's also important to remember that this might be the first time that they're seeing a doctor or seeing you, and it could take more than one appointment to build up familiarity and trust, really. Ways to kind of overcome that is that perhaps if the consultation has been a bit difficult, you could consider sending them away with a mood diary or maybe a symptom assessment score, which they could fill in between the appointments in their own time, just to give you a bit of a better idea, and it maybe helps a bit for them to explain how they're feeling or the things they're going through. Particularly with younger children, There's a number of picture scales or ones with particular numbers on a line, sort of variants of the Likert scale that can also be used to express things like happiness or how much their anxiety is affecting them in different situations. So that can be a way to kind of help the consultation. I think it's also important that if a young person comes in with other chronic health conditions, to ask about anxiety in these circumstances as well, as often it can be a gateway to talk about this. There is a lot of crossover between younger people with chronic mental or physical health conditions and symptoms of anxiety.
Thank you. Some of the key things that I took away from what you've just mentioned, which should be really helpful in future consultations, are things like the mood diary, multiple appointments, and the fact that it can be really useful to see young people alone. So that's something that I will definitely take away from what you've just said. The article mentioned screen time and social media. Has this been found to have a significant impact on depression and anxiety in young people?
Yeah, so screen time is definitely a hot topic at the moment. However, I think it's important to remember that it's not a new problem. And there's been studies for quite a while that have shown that watching age-inappropriate television and online content can affect the well-being of young people. I think the real difference more recently is that the quantity and the level of connectedness that goes with screen time has increased amongst many young people. And while increased rates of anxiety, depression and sleeping problems have been reported in young people that frequently use their phones or screen time, there's also been a number of positive impacts of screen time that have been described in young people, including distraction from the stresses of everyday life, linking up with friends, and helping to build new social networks. So I think there are some key things that we should be asking about when discussing screen time with young people and their parents. So one is about social media usage. With social media, there is the risk that the young people can be exposed to quite a large number of images of attractive individuals living idealized lives. This can lead to young people comparing their lives with these celebrities or other prominent people, and can trigger feelings of personal unhappiness when they're compared, and anxiety about their own life situation, how they look or how they might be seen by others. And of course this can affect their well-being and mental health. Excessive screen time can also substitute face-to-face contact and reinforce symptoms of anxiety and avoidance. Problematic smartphone usage, or PSU, is now a recognised phenomenon with anxiety caused when you're away from your phone for too long. Cyberbullying is also increasingly common among young people. This can have a huge emotional and mental impact. And there's a number of cases where that's gone on to trigger self-harm and even suicide.
So you've highlighted a number of issues that can be associated with screen time and social media. How can we address this as GPs?
Well, beyond taking a thorough history and getting an idea of how it's affecting a young person's life, I think there are several things that we can do as GPs with regards to screen time. Firstly, I think it's important to remember that screen time is something which is a key aspect of many young people's lives. Telling them to stop using their phones or have less time with screens often just won't be understood and risks breaking any rapport that you've built. And this is the world that they live in, and it's what many people around them their age are doing. A number of colleges, both in the UK and the States, have recommended having, or encouraging at least, open discussion between parents and young people about screen time limits, the content that they're looking at on the screens, what reasons justify using a phone or a screen, and the impact that the phone is having on any physical or social activities, including sleep. And with that, thinking about what a child is able to manage and needs in terms of their age and stage of development. I think it's also important to encourage parents and caregivers to set good examples of screen times themselves, particularly when they're with their families. I think having or encouraging house rules, like maybe having time out options on devices, and usage monitoring applications can be one way of helping to keep that balance, as well as maybe having phones charging downstairs or away from bedrooms, so that it doesn't interrupt sleep. Other ways or things that can be useful can be perhaps not having phones during meals, and trying to discourage snacking alongside using screens, as that's been shown to be associated with obesity.
Thank you for that. I think a really important thing that you highlighted is encouraging parents and caregivers to set good examples, because it's really easy to tell young people to put the phones away, but if we're always on our phones ourselves, then I can see how it can be an issue. Finally, what is your take-home message for GP trainees on this subject matter?
So I think there's a few points that are worth taking home on this. So firstly, that anxiety, or the frequency of anxiety, is increasing in children and adolescents, and it can present in a wide range of ways. It's definitely important to ask about it in young people with other chronic physical or health conditions. As part of that, it's particularly common in young people with autism or ADHD. Now, NICE guidelines recommends the same psychological and pharmacological interventions that you consider in other young people with anxiety disorders, in addition to specific behavioural techniques that can be used within these conditions. When taking a history from a young person, it's important to ask about their home, school and online situations, including smartphone usage, and how this affects their lives and the way that they're feeling. And I think finally, it's good to know that there are a lot of different support organisations and self-help resources for anxiety available to young people, their parents, and also caregivers and schools. I've listed a number of these in the article, but I think two that are particularly good is the Mood Cafe, and there's a series of different apps. There's one called Tutu, which is probably quite good for bullying as well. But yeah, they're all in the article.
Thank you so much for sharing your insights into what can be a daunting topic area. And I do have to confess, I did take a little picture of the resources that you mentioned, and I've kind of got it starred on my phone so that if I ever forget, I can make reference to it. But thank you very much for doing the interview today.
Thank you for that, Matilda. Really interesting, and I certainly have learnt so much from that. As you were saying, it's not a topic I think as GPs get a lot of training practice in, and it's really nice to just know little things that we can actually be telling our patients, families about what they can do in terms of managing anxiety, because certainly we are seeing a lot of it, and I'm sure we'll continue to see a lot more as well. Let's just talk a little bit about your interest in getting into these podcasts, because we're always really keen to have trainees, trainers, GPs coming on board and doing this sort of thing. How did you develop that interest, and what made you sort of get involved in this?
I guess I think I'd listened to a few, and I'd quite enjoyed it. And I think every now and again on the back of the InnovAiT, if anyone actually reads the back cover like I do, there was a call for, if you wanted to get involved with the podcast, then this is where you emailed. And I think the other thing is, I quite like podcasts, actually. I think they're quite a nice kind of bite-sized way of giving people information without having to be glued to a book or a computer.
No, definitely, I agree. I think certainly my drives into work very much are listening to podcasts, and there are so many out there as well. Did you find it quite helpful during your GP training as well?
Yeah, I did. There were quite a few that I listened to, which I liked. I think there was one that springs to mind. I think it was an interview that you did with Dr. Duval on trainees in trouble or something like that, and I quite enjoyed that one, actually.
Brilliant. Thank you. We're always very keen to have people come on board, and if our listeners are interested, like Matilda has done in joining us and doing some podcasts with us, you can always get in touch with the InnovAiT team and let us know. So let's talk a little bit now about your life post-CCT. So you're currently working, as you were telling me, as a salaried GP, 3 days a week at a practice in northeast London. How's life been for you, having gone through all your exams and everything, and again, in the middle of COVID, taking on your salaried role?
I would say life has been brilliant. I think I'm definitely an advocate for not working the full 5 days.
Yeah.
I think it's nice because I have my 3 clinical days, which are very full on. I get to speak to my patients over the phone. I bring some of them in. I see some of them. And then obviously I kind of have like my Monday and Tuesday to kind of do my own thing. So I'm currently doing a spin fellowship. Those have become quite popular now, and I think most of those have been born out of the long-term plan for the GPs, trying to kind of keep newly qualified GPs kind of, in training and trying to give you a bit of a work-life balance. So as part of that, I'm doing a PG cert in clinical education. So I have my lectures on Tuesday mornings, so that keeps me busy.
Brilliant.
And I guess Monday is my day to just kind of catch up on things and, do that dreaded life admin that we all hate.
Absolutely. How, what would you say are the main struggles for First Fives at the moment, in terms of building an e-portfolio, work prospects out there, and like you say, developing your special interests? How has all that been for you and your colleagues?
I think the key thing is, obviously, when you finish GP training, I guess especially in the midst of the global pandemic, quite a few of my friends were like, I just need a few weeks to breathe. So I think one thing that GP trainees need to realise when they're finishing is that there isn't a rule that says that you have to start work straight away. So if you can afford to, you are allowed to delay. And if you are looking for jobs, then you just simply need to let them, most workplaces are quite flexible and they will ask you, when do you want to start? Or they'll let you know this is when you need to start by, and you can reach some kind of compromise. E-portfolio is definitely very, very interesting, because I would probably say that because obviously everything is so busy, it can be a little bit easy to neglect it. So what I would probably say is, whilst you might not be able to do the physical entries there and there, I just bought myself like a little physical diary. So whenever I do things, I just kind of drop them down in there so that when I have my life admin day, eventually at some point, I'll put it all up onto my portfolio.
There's a lot of discussion, isn't there, at the moment, Matilda, about trainees not getting enough exposure or experience with their working time directives. Have you found that in your work now, that your training in any way was compromised, either through COVID or the working hours, and it limited your experience now working as a GP?
I think what I would probably say is that I am definitely grateful that we started remote consulting when we did. And I think because so much of medicine up until this point has involved everybody doing face-to-face, and telephone kind of being shied away from, or the opinion that there's only certain things you can do via telephone, I would probably say that the time that it happened to us was good. And I think for new trainees, they will probably be in a slightly better position than us, because obviously much more of their training would have been remote. In terms of the working time directive, what I would say is, there is always that niggling concern that, are we seeing enough patients? But I think, as one of my bosses said to me, I think probably in the first 3 months of you qualifying, you're on a big learning curve. So any gaps that you have, you will get filled, because you're seeing so many patients with so many different things. And I think what we mustn't do is take away from the fact that actually when you're in training, maybe seeing less patients gives you time to, because I remember I certainly reflected on I had time to reflect on cases and how I'd managed them, and I had time to look back to see, that patient that I saw, what happened to them. And I think if you fill the timetable with too many patients, then trainees won't have that opportunity to do that.
Yeah, that's a very, very valid point. Right, let's move on to our next podcast interview. This is about hair loss with Dr. David Milton. So how did you get into doing this podcast? What were your thoughts behind that, and how did that go?
I think, again, as a trainee, I'd had lots of patients present, male and female, presenting with hair loss. And I think 1 or 2 of the CSA books that I used had a case on male and female hair loss. And I think it's a really distressing thing for patients. And I think oftentimes as a GP or as a trainee, we're not really sure what we should be doing. Should we be worried? Should we be doing tests? Is there any good treatments for it? So I really enjoyed reading this article. It was a breath of fresh air for me, because I was like, now I know what I should be doing, and now I know what I should be saying about the available treatments and the reality of hair loss and whether or not the hair's going to come back, and the different types of hair loss. So, I really enjoyed this article.
Great, well, let's have a listen.
Today I'm joined by Dr. David Middleton, a dermatology registrar based in Belfast, who co-authored an article on female hair loss in July's edition of InnovAiT.
Hi, how are you?
I'm fine, thank you for joining me.
That's no problem.
During our first assessment of a female patient presenting with hair loss, is a full examination completely necessary?
Yeah, I think that's a really good question. The article kind of goes through the different types of hair loss that can frequently present in females. I think a full examination here really just gives kind of clues and pointers for possible differential diagnoses. So, in the article, it mentions about types of alopecia, you get nail changes.
Mm-hmm.
So all these things are particularly useful to point you in a particularly useful direction of what type of hair loss this might be. I think the other big one would be is it's useful for full examination for the androgenic or the female pattern hair losses, just to make sure that there's no signs of androgen excess, especially in your female patients. I think just even a quick examination of characteristics of development is really, really useful, and it can just point you in the right direction from the outset of where you're going, especially when you're kind of counselling these women and talking about possible diagnoses.
Thank you for very carefully highlighting the kinds of things that we need to be looking out for. So in regards to hair loss caused by drug side effects, can patients expect their hair to grow back once the drug is stopped?
Yes, so whenever you're looking at drug causes in hair loss, often it kind of comes down to two broad categories. There's the telogen effluvium, which the article does mention, and then your anagen effluvium. Now, your anagen effluvium is usually things such as your cytotoxic chemotherapies, which we wouldn't really see in dermatology practice. With regarding kind of your drug-related telogen effluvium, so typically in telogen effluvium, the onset of increased hair shedding is usually a couple of months or 6 months up to the insult. It can occur quicker, especially in the drug-related telogen effluviums, where it could be weeks to months after the introduction of the drug. The reassuring thing is that usually there is slow regrowth. On average, some of the articles quote it in it being on average between 3 to 6 months. But again, I think being open and honest with patients, there's other reports that say it can take up to 1 to 1.5 years. So like quite a lot of these things related to female hair loss, it's often quite difficult to be confident in prognosis. So it's being really open with patients and letting them know these are rough estimates, but things can always be shorter or longer than what's suggested.
Thank you so much for shedding light on that. It's really helpful to you've said that we have to be open and honest with patients, but it's really helpful to at least have a kind of time frame that we should have in mind.
Yes, exactly.
And I think actually it allows us to just give patients not so much hope, but an idea of what is yet to come.
Yeah, and I think that in general practice and in primary care, you know these patients better than we do, who see them for their first review. So you're in a really good position to kind of know that patient, know what their expectations are, and what information they want to know about the condition.
Thank you. On the other hand, in patients with trichotillomania, how do we go about making a referral so that patients can receive psychological help?
I think that's a really good question. It really just highlights, I suppose, issues with provision of services such as psychological support. I would think broadly it varies depending on where you're working in. Some places may directly accept referrals from primary care into it. I know even from a tertiary care point of view, it's really difficult sometimes to get the capacity in psychological support. There's some useful information on the NHS England website that does kind of direct you. There is a trichotillomania group, and they actually have links onto it regarding the types of therapies that I've mentioned. But in all skin disease, not just hair loss, it's actually very difficult to get psychological support for patients in general, and especially where it's things such as breaking habits. There's a big need for that service, but unfortunately, it varies to where you work in, and even the process of referral varies greatly across the country.
I think, based on what you've said, even having the knowledge that it can be difficult is helpful. Because it helps us to, set patients' expectations, and even knowledge of things like the trichotillomania group. Even if we can't get a formal method of supporting patients through formal psychological help, I think it's nice for patients to know that there's a group and there's other people who are going through what they're going through.
Yeah, and it's mentioned in the article too, there's quite a few centres which will have dedicated multidisciplinary psychodermatology clinics. Often these clinics, you'll have the support of psychology in-house. So if there's access to that and that's suitable for the service you're referring to, that's a great resource to have, especially for treating these conditions, which are often very difficult without it.
Thank you so much for sharing that insight.
Yeah.
Finally, what is your general take-home message on this topic for GPs and GP trainees?
I think female hair loss is such a difficult thing to treat. So I always find in kind of my own practice being really honest with the patient. So once you've kind of went through your differential diagnoses, getting the diagnosis, often it's just being completely honest with the patient regarding what treatments are available and what treatments aren't. And I think that's very difficult for patients to, often waiting lists are very long. They've been waiting for several months or even years to get this appointment and kind of holding out hope for that. And often it's just having to be honest from the outset, depending on which type of hair loss they're suffering from, that of the limitations of each treatment and what they can expect. The article does talk through some of the treatments and says there you can see reversal in some of the reversible causes, but often it's not to kind of a cosmetic satisfactory level. For any of these conditions, regardless of the cause, patients often do need hair appliances, and again that'll depend on where you work, if that's from tertiary care or primary care, but even just raising that subject with patients too regarding hair appliances or wigs is very difficult. Personally, I really feel strongly that it's just being honest. If you've got the diagnosis, got your suspicions, it's being honest with patients, whether that be talking about telogen effluvium and explaining this is likely just following an insult, whether that be psychological or physiological, and that hopefully things should improve, or with the more scarring causes, hinting that we're going to dermatology, they may want to start treatment to see if they can halt this process. And I think that's from us too as specialists, and also again you've often known these patients for many years as the primary care, that's them so well, and I just think that being honest about the prognosis and honest about the treatment options from the outset.
Thank you so much for that. So I think the message that I perceive based on what you're saying is, obviously in primary care we know our patients, so helping them to manage their expectation before they get to the dermatology clinic can be helpful in making the best of their appointments. Is that fair to say?
Yeah, and I mean, I think at the minute in terms of treatment options, and the article does go into it, we're often quite limited. There's some discussion about use of JAK inhibitors as a new emerging topic, but it's difficult to know how far off we are. But that kind of honest thing with patients and saying, yes, there are new drugs potentially coming out, but it's being honest of what we have at the minute and what they can expect from it. And it isn't it extremely frustrating to explain this to patients, in regards of treatment options. But I think having that conversation is useful to patients to just know what their prognosis is and what they can expect.
Thank you so much for agreeing to do
Thank
the
you.
InnovAiT interview today. I am sure that all of our listeners will definitely appreciate the further insight into female hair loss.
Thank you for that, Matilda. Again, a really interesting interview. I'm learning so much here. Hair loss, as you're saying, we do come across it quite a lot, and sometimes just knowing, what tests you need to do, what not to do, and when to refer. So again, a brilliantly conducted and led interview with Dr. Middleton. And again, for our listeners, you can access all these interviews online on InnovAiT as well on our website. So, Matilda, let's have a little chat about burnout. We've talked a bit about it already, and how we manage work-life balance. It's easier said than done, I think, for all of us, and at the moment, much, much harder. Tell us a little bit about your experience. How, again, has these last few months been, and how do you try and manage your work stresses after a horrendous day at work?
Yeah, I think the one thing that myself and my friends and my colleagues have noticed is that obviously, pre-COVID, you could, there would be weddings, there would be gatherings, there would be someone's birthday. So, even though as doctors we're so busy, the great thing would be someone was going to get married and we were all going to converge on that wedding and have a good chin wag. Whereas, with COVID and lockdown restrictions, you can't actually meet up with people to get that peer support in the same kind of way. But not necessarily me, but my colleagues have been really good with, at the peak of the pandemic, like setting up like a weekly Zoom call where we would all get on, when doctors get together, we have a good moan and, be like, this is what I had this week. This is how I feel about it, and this is what was really good this week, and it was actually quite therapeutic. I mean, I know the thought of groups of doctors getting together to moan, it
doesn't sound very stressful, but it is. No, absolutely. There's huge value in that, isn't it? And as we're seeing, Balint groups are really coming up again, aren't they? Because when we don't have so much face-to-face contact, it's really important that we still have a means to be able to share our thoughts, our concerns, and who best to do that with than colleagues who actually know exactly what you're going through and probably are experiencing similar things. That's really important about that sharing, isn't it? And it's really nice that you were doing that, because I think one of the things I really missed after VTS was not having that group contact with my peers. And sometimes, in general practice, even though we might be in a practice with 6-7 other doctors, it can still be very isolating because you can be stuck in your room and even have your lunch in your room. And before you know it, it's been 12 hours in a day and you've only had contact with patients and nobody else in the building. So, really, really important that, as you mentioned. Other thing that just came to my mind, also we talk a lot about GP recruitment, don't we? How would you say, in general practice, we can try and, promote general practice more to trainees, to medical students? Do you think we're doing that as we should be? What other avenues are there for us to be able to sell our profession out there?
I think, and this is a difficult one, because what I would say is I think all medical students and all GPs now have had that experience where you're a student and there's a lot of GP bashing, and I think even as a GP now, probably as a student, I've probably GP bashed myself, but I think it's about changing the image and having an appreciation and respect for what we do, because I think now being fully qualified, we hold so much risk, we hold so much responsibility, we have so much autonomy. We're like the jack of all trades, master of none. And, even in the midst of COVID, we get the letters from the hospital and, it all falls back to us. GP, please can you arrange X, Y, Z?
Absolutely.
And I think, just letting, students know that it's not just about, social and having a chat, but, we are managing very real, medical, complex social issues. And it is really rewarding. And patients are really grateful. And actually, the continuity, some people don't like the idea of it, but it is nice to, manage a patient and 2 weeks later be able to go into the records and see, what happened to that patient that I sent to A&E, and actually being able to complete the loop.
Yeah, no, absolutely. That's very, very true. There is a huge advantage in that, isn't it? When we build that relation with our patients over years, we get to know them, we get to know their families,
Exactly.
we share that journey and go through so many things with them, don't we? So there is huge job satisfaction and very rewarding, as you say. So we'll move on to our final podcast, our final interview for today, which is on gout. Again, a very relevant topic. We do see gout quite a lot, don't we, general practice, and knowing in terms of how managing it, having the up-to-date guidance on that, which often keeps changing as well. It's always really helpful. So let's have a listen to this podcast and find out a bit more about this.
Today I'm joined by Dr. Liam Hannaway, a GP partner based in Cardiff who has a special interest in minor surgery and joint injection. We'll be discussing gout, which featured in the October edition of InnovAiT.
Thank you for that, Matilda. Yeah, I'm a GP working in Cardiff, and I'm also a GP trainer, which is how I got round to writing the article for InnovAiT.
One question that was on my mind after reading the article was, is there still a place for joint aspiration in diagnosing gout? Okay.
Yes, I think there is still a place for joint aspiration in diagnosing gout. I think it's still considered to be the gold standard for diagnosing gout, but the difference is really that in general practice it's not really practical. So I think if patients are ending up in the hospital, then they would probably still look to perform a joint aspiration. However, in primary care, then the diagnosis of gout is usually clinical, and we can use some scoring tools sometimes if we're not sure to try and help us if we want to. The other place where aspiration of the joint could be useful in primary care with gout would be you could aspirate and inject the joint at the same time as a therapeutic intervention if it was just a monoarticular gout and you were obviously confident with the diagnosis and confident to do that.
Thank you for that. That was really insightful. How straightforward has it been in practice to reduce urate levels within the target range?
I think this has been quite a challenge both for doctors and the patients in two ways. I think traditionally we were probably quite used to maybe just starting people on allopurinol and thinking that was the job done and not necessarily following them up. And similarly, I think for some of the patients who've been on allopurinol for a long time, they've maybe then been surprised to all of a sudden be getting called back and saying, well, we'd like to check your urate level and actually we need to change your dose. So I think it has resulted in more appointments for patients and also more blood tests. So again, that takes a little bit of getting used to, but I think really it's only the same type of thing that we do when we're maybe titrating up somebody's ACE inhibitor. So I think as we get used to the practice again, I don't think it's going to prove a big obstacle. But yes, there has been a slight change and a slight difficulty sometimes in getting people in for appointments.
So it definitely sounds like something that's been received well by the patients.
I think so. I think people are happy to have some interest being paid to them. I think the other big thing that came out of the updated guidance was that patients should be given a lot more information about the gout. As I say, gout is one of those things that people are kind of aware of but don't really understand necessarily the full implications. And so providing people with that important lifestyle information as well, empowers them a little bit. And I think they're interested in finding out a bit more about the disease.
Thank you for that. When should we consider referral to secondary care when we're managing patients with gout?
So yeah, I had to think a little bit about this because I think a lot of gout is probably managed entirely within primary care. However, there are still some instances in which we would want to, and NICE also provides some guidance for this on us. Certainly, if in an initial presentation we're worried about a septic arthritis, then we should certainly refer patients up to secondary care for further testing. If we've got some diagnostic uncertainty, whether we think maybe these symptoms may be due to an underlying condition or connective tissue disorder, and then
The other groups mainly would be either the complicated groups, so maybe if you've got gout in a person less than 30, if you've got somebody who develops gout in pregnancy, and maybe other people with maybe renal problems, because the drugs that we use, we do need to monitor renal function carefully, and so if you've got somebody who's already got compromised renal function, then we might need some further guidance. And I suppose generally anyone who either is failing to respond to treatment, can't tolerate the medications we'd be comfortable with, and people we can't get down to target. So there is actually still quite a wide range of people who we might need to involve secondary care with, although I think it probably doesn't happen that often.
That was really helpful, just to clarify that, because actually after reading the article, I kind of got the feeling that this is very much a primary care issue, and I thought there must be some times when we have to refer in. When do we have to refer in? So that was really helpful. What is your take-home message for GPs managing gout?
Okay, so I think there's a couple of take-home messages. I think the first one would be to say that we shouldn't consider gout to be a benign intermittent disease anymore, and we should consider it actually to be a chronic inflammatory condition which, if left untreated or undertreated, could actually result in quite long-term pain, disability and deformity for our patients. And then I think the second thing to consider would be that we shouldn't think of gout in isolation, and we should think of it as part of a wider metabolic type syndrome associated with other risk factors for cardiovascular disease. So when we see someone with gout, we should also screen them for these other things and treat the whole picture. And maybe the third thing to say is just to make sure that we're giving people the information at diagnosis to inform them about the disease and also how they can manage it themselves.
Thank you so much for providing us with lots of useful information that we can all take home and apply to our day-to-day practices. Thank you.
Thanks again, Matilda. Great, again, a really informative, very insightful interview on gout. I'm sure our listeners will have taken a lot from that. So as we come to the end of our podcast today, there is obviously lots we've covered, lots we haven't. One thing I suppose that can't really go without being mentioned is the huge vaccine rollout that is happening all across the nation at the moment, and I'm sure you and your practice as well, Matilda, have been involved in this. In the area where you work, as you were saying, there's quite a large, it's a mixed population, you've got quite a large ethnic population as well. How has all of this been for your practice? Have you been directly involved in the vaccine rollout programme as well? And how are you reaching out to those patients who have shown a vaccine hesitancy, and how are you trying to address this with them?
Fabulous. So in terms of how we are doing the vaccine rollout, so our CCG has decided that it should be kind of done at one central place in the area. So the role of the practice essentially is to phone patients and book them into that centre. And actually, generally in the main, patients have been very kind of receiving of it. In fact, I've had patients who are like, they haven't called me, when is it my turn? And I was like, it will be soon, it will be soon. But, equally, I've had, appointments booked just to discuss the COVID vaccine and to discuss people's concerns. And, generally I just kind of talk through things, talk through, the data we have, talk through the fact that, lots of people have had it, and actually, people need to be protected. We need to kind of see a way out of this. And in the main, most people are looking on the vaccine as kind of a source of hope. And if it's not completely a source of hope, then at least some kind of reassurance that, they've kind of done what they can to protect themselves. But in terms of the difficult conversations, I think it's just about, making sure that patients are making an informed decision. Everyone has the right to say yes or no.
Yes, absolutely.
But I think for me as a doctor, it's really important that patients know why they're saying yes, and they know why they're saying no, and they know, we've got all these like WhatsApp dramas, and people like, oh, I got this message and it said that this is, and just dispelling the myths with them when you speak with them as much as you can within your 10-minute consult.
Yes, no, that's really important, isn't it? It's trying to address people's concerns and understanding where they're coming from, because sometimes people will listen to and take what they want from the information.
Exactly.
And there is so much misinformation out there, so it's really important to reach out and give them what is the right information about this, and hopefully be able to reassure them, which I know, many CCGs, many practices have been doing, and I think the response certainly is that patients are listening, are understanding how important it is, and that's really great. Have you been involved in the vaccine program yourself as well?
So I haven't given any, unfortunately. I think because, as I said, I'm the only one on site, I've been very much at the practice, but I have been managing, kind of when patients have phoned up about, post-vaccine concerns and, I've got this, or what do you think? Can I still have it? And I think also I've been getting calls where, patients who have allergies to find out whether they can still have the vaccine. So that's the main role that I've been playing. Brilliant,
and a very important role as well. So as we come to the end of our podcast, it's been absolutely wonderful talking to you, Matilda. Really, we've covered a journey, I think, from your training to life now, and hopefully life after COVID as well. And we were talking about this, weren't we, before the interview as well, how we see things moving forward. And you mentioned obviously hope of how things are going to be in the future. I guess on a personal level, what's all this meant for you personally? Has it changed your perception of things, the way you practice medicine, the way you deal with your patients, and actually what constitutes care? I suppose that's changed much, hasn't it, in so many ways? What sort of experience have you had, and what are your thoughts about that?
I think the main thing that I've probably been bothered by is probably like health promotion and, trying to encourage all my diabetic patients and kind of being a bit firmer that, we need to get your diabetes under control, we need to get your blood pressure under control, we need to get your weight under control, and all those kind of things. Not that you didn't do it before COVID, but COVID has kind of given those kind of things a new meaning, because you want to make sure that you're optimizing your patients as much as possible, so that if for whatever reason they do contract it or they just get ill from anything else, or for me, I know as their GP, I have done everything I can to make sure, their sugars are under control. And actually, over the last few months, I have noted that, when I've had those frank conversations with patients, they do appreciate it, and I have seen the change. And I've had the pleasure of being like, look, your blood sugars are so much better than they were when I spoke to you last time. Like, whatever you're doing, it's really good. So I think kind of more of just the partnership with patients and helping them take responsibility and empowering them has been important to me.
Yeah, that's a really useful point. Yes, that's very true. And on a personal level?
I think just, I guess, the need to rest, if that makes sense.
Yes.
So, you have your busy day, whatever days it is that you work, but just making sure that when you're not at work, you're resting. So for many years, I've had a general rule that I don't get my emails sent to my phone. I'm very old-fashioned, and I still have to log in to check my emails, and I guess that's my way of switching off and resting.
Yeah, and having that awareness, isn't it, what we need to do to look after ourselves.
Yeah. Exactly.
On that note, we will call it a day today. It's been brilliant. Again, I really appreciate you taking the time out for joining us for the interviews, which have been so useful, so informative, and I'm sure our listeners will have found it equally so. Once again, lovely to have you today with us, and we hope we can get you back for more of these in the future as well. Matilda Essen, our salary GP, joining us for our podcast today. With that, we'll sign off, and we hope to see you for our next edition soon. Thank you.